Acute kidney injury, a deep dive into definition, causes, diagnosis, and management. Welcome to our podcast, where today we take a comprehensive look at the topic of acute kidney injury, a condition that is both common and serious, especially among patients in hospital settings. Acute kidney injury, previously referred to as acute renal failure, is characterized by a sudden decline in kidney function that develops over hours or days. Although it can often be reversed, this syndrome carries significant risks, including increased illness and death. Understanding acute kidney injury. Acute kidney injury is recognized by a swift reduction in the ability of the kidneys to filter and remove waste from the blood, resulting in the buildup of substances such as urea and creatinine. There is also a disturbance in fluid and electrolyte regulation. For diagnosis, clinicians use internationally accepted guidelines, specifically those from the Kidney Disease Improving Global Outcomes Organization. According to these guidelines, acute kidney injury is present if there is an increase in blood creatinine by at least 0.3 mg per deciliter within 48 hours, or if the creatinine rises to at least 1.5 times the baseline value in the previous week, or if urine production drops below 0.5 milliliters per kilogram per hour for 6 consecutive hours. The severity of acute kidney injury is classified into 3 stages, which are determined by the extent of the creatinine increase or the decline in urine output. The causes and mechanisms of acute kidney injury. To better understand acute kidney injury, it is helpful to categorize its causes based on where the problem originates. This classic approach divides the condition into 3 main types: prerenal, intrinsic renal, and postrenal. Prerenal acute kidney injury. Prerenal causes account for a large proportion of cases. The underlying issue is a reduction in blood flow to the kidneys, although the kidney tissue itself remains structurally normal but is underperfused. If blood flow is restored quickly, kidney function can often recover. Common causes include dehydration, significant blood loss, severe diarrhea, and burns, all of which lead to low blood volume. Conditions that reduce the heart's ability to pump blood, such as heart failure or a heart attack, can also cause prerenal injury. Other contributors include widespread blood vessel dilation seen in sepsis or severe allergic reactions, and medications like nonsteroidal anti-inflammatory drugs or certain blood pressure drugs, especially when the patient is dehydrated. Intrinsic renal acute kidney injury. Intrinsic renal causes result from direct damage to the kidney itself. This group includes several subdivisions. The most common is acute tubular necrosis, which arises from prolonged low blood flow or exposure to toxins like certain antibiotics, contrast dyes used in imaging, or myoglobin released from muscle breakdown. Other types of intrinsic injury involve inflammation or damage to the filtering units of the kidney, such as rapidly progressive glomerulonephritis, or allergic reactions affecting the kidney tissue, often due to medications like antibiotics, proton pump inhibitors, or nonsteroidal anti-inflammatory drugs. Diseases affecting the kidney's blood vessels, such as vasculitis or malignant hypertension, also fall under this category. Postrenal acute kidney injury. Postrenal injury is caused by an obstruction to the flow of urine. This leads to back pressure, which can harm the kidney, but recovery is often possible if the blockage is relieved promptly. Common causes include an enlarged prostate, prostate cancer, bladder stones, or narrowing of the urethra. In some cases, cancers or fibrous tissue in the area can block both ureters, the tubes that drain urine from the kidneys. It is important to note that for an obstruction to cause acute injury, it must affect both kidneys, unless the patient has only one functioning kidney. Diagnosis and evaluation of acute kidney injury. Effective diagnosis begins with a thorough history and physical examination. It is crucial to review any medications the patient is taking, such as nonsteroidal anti-inflammatory drugs, antibiotics, or diuretics, and to look at symptoms including changes in urination, swelling, or pain in the side. Past medical conditions like diabetes, high blood pressure, and heart failure, as well as recent surgeries, infections, or exposure to contrast agents, are all important considerations. During the physical examination, healthcare providers assess the patient's fluid status by examining the veins in the neck, checking skin elasticity, and looking for swelling. They also look for signs of heart failure, measure for a distended bladder, and check for skin rashes that might suggest an allergic reaction in the kidneys. Urine tests are vital for distinguishing the type of kidney injury. A simple urine analysis can reveal specific findings, Bland urine or hyaline casts may suggest prerenal or postrenal causes. Muddy brown granular casts point to acute tubular necrosis. The presence of white blood cells or their casts indicates interstitial nephritis, and red blood cells or their casts suggest glomerulonephritis. Additional tests can assess how well the kidneys are conserving sodium and concentrating urine, but these may be less reliable if the patient is on diuretics or has chronic kidney disease. Blood tests are used to measure creatinine and urea, helping doctors diagnose and stage acute kidney injury. Electrolyte levels are monitored for dangerous imbalances such as high potassium, acid buildup, low sodium, or high phosphate. A complete blood count can reveal anemia or increased eosinophils, which may suggest certain types of kidney damage. Imaging, especially a kidney ultrasound, is essential for checking for urinary tract obstruction and assessing kidney size. In rare and unclear cases, a kidney biopsy may be performed, especially if glomerulonephritis or interstitial nephritis is suspected and does not improve after stopping the suspected drug. Management strategies for acute kidney injury. General principles and supportive care. The foundation of treatment is to address the underlying cause, prevent complications, and support the patient until kidney function recovers. For prerenal cases, restoring fluid volume with intravenous fluids is critical, as is treating underlying heart failure. In postrenal cases, removing the obstruction, often with a urinary catheter or surgical procedures, can lead to rapid improvement. For intrinsic kidney injury, stopping medications that harm the kidneys and treating the specific underlying condition, such as using immune-suppressing medications for glomerulonephritis, is necessary. All medications that are cleared by the kidneys need to be adjusted, and offending drugs should be stopped immediately. Monitoring the patient's fluid balance is essential, with daily weights and strict tracking of fluid intake and output to maintain a normal hydration status. Managing complications. Several complications can arise from acute kidney injury. High potassium in the blood is life-threatening and requires urgent treatment. The heart can be protected with intravenous calcium, while medications like insulin combined with glucose or inhaled salbutamol can shift potassium into cells. Excess potassium can be removed using diuretics, potassium-binding medications, or dialysis. Severe acid buildup, known as metabolic acidosis, may be managed with sodium bicarbonate if symptoms are present and blood acidity is marked. Fluid overload is tackled by restricting fluids and sodium, and using diuretics to increase urine output, though this does not alter the overall course of acute kidney injury. When symptoms of severe waste buildup, such as confusion, heart inflammation, or bleeding, arise, dialysis may be necessary. Renal replacement therapy. Dialysis is reserved for life-threatening complications that cannot be managed with medication alone. Indications for dialysis can be remembered by the acronym AEIOU: persistent acid buildup, severe and unmanageable high potassium, ingestion of certain toxins, uncontrollable fluid overload, and symptoms of severe waste buildup in the blood. The choice between periodic hemodialysis and continuous therapy depends on the patient's stability. Nutritional support. Proper nutrition is crucial to prevent the breakdown of body tissues. Intake of potassium, phosphate, and sodium should be limited according to the patient's needs. The restriction of protein is debated, but in acute situations, a more generous approach is often taken unless the patient is receiving dialysis. Long-term outcomes and prognosis. The outcome for patients with acute kidney injury varies based on the initial cause and the patient's overall health. Many cases are reversible with proper treatment, but the condition is linked to higher risks of death both in the short and long term. Some patients may not fully recover and can develop chronic kidney disease. Conclusion. In summary, the management of acute kidney injury requires a quick and systematic approach. First, confirm the diagnosis using established criteria. Second, identify the cause through careful history, examination, urine testing, and imaging. Third, start targeted treatment such as fluid replacement, relieving obstructions, or stopping harmful medications. Fourth, closely monitor and treat complications, including abnormal potassium levels and fluid overload. Fifth, initiate dialysis when needed. Finally, provide ongoing supportive care and monitor the patient's recovery. By following these steps, clinicians can improve outcomes and help patients regain kidney function. Thanks for tuning into today's episode. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the Extraordinary.